لما نكون ان شاء الله باذن الله تعالى حنناقشه في شو اسمه حلقه النقاش ونطلع باذن الله تعالى بالتوصيات المطلوبه. طيب راديولوجيكال بروسيجر طبعا في تو تايب، ايميجينج ونون ايميجينج. بالنسبه للايميجينج طبعا نقدر نوزعها بكل سهوله الى anatomical imaging, physiological or functional imaging، وفي اللي هي molecular imaging. ولو لاحظتوا ان الاكس راي والسي تي ان جنرال تعتبر من anatomical، الالترا ساوند anatomical مينلي وممكن يكون فيها شويه physiological، ام ار اي مينلي ايضا anatomical وشويه physiological وقد تدخل شويه في المولكيولر. اما بالنسبه للنيوكلير ميديسين والبيت سكان فهي مينلي molecular and physiological، اما بالنسبه للاناتومي فضعيفه جدا. نجي للاوبتيكال اتس مينلي مولكيولر وهذه اوت اوف سكوب اوف راديولوجي، فلذلك احنا ما حنتناقش فيها. اما النون ايميجينج موداليتيز اللي هي عندنا انترفيشن بروسيجر والثيرابيوتيك بروسيجر سواء كانت في نيوكلير ميديسين او في الراديولوجي. نيجي بالنسبه رول اوف ميديكال ايميجينج انكولوجي. فطبعا اتوقع الجميع يعرف انه الانكولوجي needs the radiologist almost in all steps or at least in one or more step during the management of the patients. فلذلك in summary حيكون لهم رول في السكرينينج والبريفنشن. كيف البريفنشن؟ If you screen the patient and detect the cancer early, you can prevent the complication of that cancer. طبعا diagnosis والstaging، therapeutic planning والثيرابي. طبعا عندنا امثله كثيره بالنسبه للثيرابي اللي هو في الانترفنشن الثيراسفير للليفر كانسر، وايضا عندنا فور ثايرويد كانسر الايودان 131 واذر بروسيجرز. ايضا طبعا الالترا ساوند الان تستخدم في الثيرابيوتيك للبريست كانسر. ايضا لهم رول قوي بالنسبه للفولو اب والري اسسمنت اوف ذا بيشنت. الديتيلز في هذه الاشياء حتتكلم عنها ان شاء الله الدكتوره زين عسيري كونسلتنت راديولوجي اند نيوكلير ميديسين، والدكتور فهد السهراني كونسلتنت بادي ايميجينج ويشتغل اغلب شغل الانكولوجي عندنا في المدينه الطبيه مع بعض الزملاء. فهذه حسيب التفاصيل انا للزملاء. طيب الكونكلوجن، انا حختم محاضرتي هذه. الانكولوجيست يحتاجون الراديولوجيست السيرفيس اوف ذا راديولوجيست for diagnosis, screening, prevention, assessment, whatever. لكن الراديولوجيست ايضا they need the oncologist, the feedback from the oncologist is very important. وهذا الهدف من البرزنتيشن هذه من الوركشوب هذا. To improve the quality of the service which given for the oncologist from the medical imaging or the radiology or nuclear medicine. فهذا الهدف الرئيسي من هذا البرزنتيشن، ولذلك حتكون هي الوركشوب هذا كله حيكون نقاش باذن الله تعالى، ونطلع بريكومنديشن ترفع ان شاء الله باذن الله تعالى عن طريق الدكتور سامي الشيخ الى معالي الوزير، وباذن الله تعالى ترى النور قريبا باذن الله تعالى. فلذلك نحتاج يعني انكم كلكم تكونوا اكتف معنا ومتحدث تناقشون جميع الامور اللي نحتاج بالفعل نتناقش فيها، وهي بس مسالتين: الوضع الحالي للميديكال ايميجينج في المملكه العربيه السعوديه ومستشفيات وزاره الصحه، والشيء الثاني التشالنجز بالنسبه للانكولوجيست مما يخص الميديكال ايميجينج، وبعد كذا ان شاء الله ريكومنديشن باذن الله تعالى. انا اختم محاضرتي هذه وان شاء الله قدم الدكتوره زين عسيري كونسلتنت راديولوجي اند نيوكلير ميديسين، او الدكتور فهد السهراني حيتكلمنا عن الرول اوف راديولوجي ان اونكولوجي. تفضل دكتور فهد.
السلام عليكم. معكم الدكتور فهد الزهراني من مدينه الملك عبد الله الثاني كونسلتنت بادي ايميجينج. اليوم حنتكلم عن رول ايميجينج ان اونكولوجي. I'll talk briefly about this. You know, most of our work in the KMC is oncology. It's mostly constituted 80% of our work. It's a major division in the radiology. So we'll try just to outline or to get a brief idea about our work. As Dr. Khalid, it's a multidisciplinary actually work. Radiologist and nuclear medicine is essential member of this division. And our role is making cancer visible. It starts with screening then detection and to find the primary and metastatic lesions, staging, local staging, lymph nodes, and the detection of metastasis, evaluation of the therapy response, then follow up the patients to find early recurrent tumor, restaging the patients in case of neoadjuvant therapy, then to get information about the nature of the disease by taking biopsy, and of course the imaging also play an essential role in explaining the radiotherapy. So we'll start with screening. It actually variable from country to country, depend on the healthcare system, resources, and the health concern about the population, and cultural attitudes and priorities. I'll give 3 examples for screening which can be done here. First one is mammography. We are doing this in King Abdullah Medical City. It helped to reduce breast cancer mortality by 30%. The sensitivity of mammography, which is the primary modality for screening, reported data is 85%. And the fatty breast actually the female after 45 years of age, the breast will become fatty. The sensitivity increased to 99%. In young women, the breast density is increased, so the sensitivity will be decreased. And in that case, we do ultrasounds. The radiologists usually get the final assessments by rounds, it's called by rounds, from 0 to 6. 0 mean need additional imaging. So if you see here, this is the mammography. We see around the lesions here, which is by round 0 need another imaging. By doing ultrasound, they just intramammary lymph nodes, which considers spirals 1. In case of high suspicion, the radiologist will get spirals 5. Another example is the CTC, computed tomographic colonoscopy or coronography. This one, the indication for this one is screening for colorectal cancer in high-risk group, colon evaluation after incomplete or unsuccessful colonoscopy, and to better evaluate the colon proximal to the obstructing neoplasm to evaluate for proximal polyps. This technique actually is markedly depending on the patient's preparation and bowel distension. So if the patient preparation is not good or the bowel distension is not good, the residual fecal material will give rise to false or to wrong interpretation. And of course, the positive findings need peritoneal colonoscopy and require confirmations by histopathology. Another example is lung cancer screening. Lung cancer screening can be done in people with age over 55 and history of 1 batch per day over 20 years. We can use a low dose CT, which is minus 20 to 25% of the standard dose, and it has a significant mortality benefits. For example, in the non-small cell lung cancer stage 1A, it increased the survival rate to 65%, and if it is more than 1 centimeter, the survival rate will be 80% survival. And this is, in this study, they mentioned that there is 36 to 53% survival increase in the low dose CT group. And this one is a Langerhans recommendation. The radiologist will get a category from 1 to 4x and recommendation for screening or further maintenance according to the radiological findings. We'll move to another thing in the radiology is tumor detection. And actually, the ultrasound and CT are generally less expensive and more widely available than MRI, and therefore used as a baseline study most of the time. The imaging modalities, as Dr. Khalid mentioned, divided to anatomical and functional, molecular. The anatomical is X-ray, ultrasound, angiography, and MRI, and the functional imaging, SPECT, PET-CT, and in the MRI we have MRSI, diffusion weighted images, perfusion CT and contrast-enhanced ultrasound. Contrast-enhanced ultrasound will give intravenous contrast and see the tumor neovascularization. Perfusion CT detects also the tumor vascularizations. Diffusion-weighted images, restrictions, and the MR means cellular or cellular tumor. MRSI to detect the chemical status of the molecular products. The role of conventional X-ray is limited. Maybe the chest X-ray, we can use it to detect lung cancer or lung nodules, and also for complications like pneumonia, for example. Skeletal, the baseline for skeletal tumors is X-ray. For metastasis or for also characterization of the primary tumor, mammography as we say. Abdomen, the role is very limited, maybe to see bowel obstruction, for example, here the colon cancer, and here you can see a full metastasis. Ultrasounds is not the standard tool for the tumor evaluation, but the advantage of ultrasounds is easy, accessible, excellent soft tissue resolutions, non-invasive, real-time information, but it is operator dependent. And this is the major disadvantage of ultrasounds, and the lack of complex information, difficult to evaluate the deep structures and big lesions, lack of bone evaluations, subjective and technical dependence. Can be transcutaneous abdominal, pelvic, neck, breast, extremities, all this can be done in the rectal, endoscopic, or intraoperative ultrasound. And the major role also is the ultrasound guided biopsy and drainage. CT is a quick, whole body information, high spatial and high contrast resolution. And volumetric measurements is very important in CT. Lots of tissue information, and also this demonstration of the bone cortex, but not the bone marrow, and delineation of the calcifications. And this is a few examples of CT. This is a trochanea tumor extension to the nasal, sinuses. Here, multiple lung nodules, metastasis, here bone metastasis, CT guided biopsy from the liver tumor, and this is a big pelvic mass with soft tissue extension, with cutaneous extension. And this is example for the volumetric measurements of the CT. You can see the median seeing the mandible, and this is 3D for the bone, and this is the angiography 3D. The MR, the MR is giving complex information of the tumor spread with a high spatial and high contrast resolution. Best soft tissue evaluations in case of new CNS tumors, head and neck tumors, pelvic, upper abdomen, and also the extremities, and also the breast. And it can give tissue-specific information. It can differentiate fat from melanin, from blood, and we have also hepatocytes and risk-specific contrast agents. Functional information, dynamic contrast enhanced MRI, give functional information, diffusion-weighted images, MRSI as we describe, spectroscopy, flow sensitivity, and MR angiography is another example. So in the brain tumors, the sensitivity, there's an 80% improvement in assessment of tumor volume by MRI. Nasopharyngeal cancer CT MRI will get 50% better staging. Prostate cancer CT MRI get 52% improvement in staging. Gynecological tumors, the MR accuracy reach 90%. Rectal cancer, the MR accuracy reach 80 to 90%. So this is an example, brain tumors in the four ventricles. This is contrast enhanced T1 weighted image. Another example is here, the brain metastasis in the cerebellum here. MRI, breast, and this is tumor in the breast. Metastasis in the spine, nasopharyngeal cancer with extensions to the soft tissue in the neck. Liver lesions, metastasis or primary, prostate, rectal tumor, and also endometrial cancer. This one is an example for the tissue-specific information. These patients have two primary, colon cancer and ocular malignant melanoma. You can see here that there is a hypoechoic lesion, unspecific. We did MRI and shows high T1 signal intensity lesions, which indicate melanin content. So the metastasis here from the ocular malignant melanoma. Also, to give tissue-specific information, the MR spectroscopy, for example, this is a lesion here in the brain. We did the spectroscopy, and it shows increased choline peak, which indicates malignant tumor, in this case, glioma. We will move to the common tumor staging, and we talk about the breast. For breast, as we said, we start with mammography, then ultrasounds, recommended by radiologists. Some guided biopsy taken by mammography, by ultrasound, include FNA, core, cyclone-assisted biopsy, and stereotactic biopsy guided by mammography. MRI can be done in certain cases. Localization before operations, for example, top layer, and CT done for distal staging, and also bone scan for bone metastasis. Here, for example, there is speculated lesions, Pilar's 5, indicating malignant lesions, and this is a lesion taller than 1, which is a features of malignancy, and this is the tumor in MRI. The mammography plus ultrasound plus biopsy has a sensitivity of 85%, a specificity of 92 to 95%. MRI has better sensitivity. And for sentinel lymph nodes, lymphoscintigraphy plus histopathology has a sensitivity of 94%. This is a lung cancer staging. Primary, we are doing a CT for the staging and has T accuracy of 90%. The role of MR is just to evaluate the metastasis in the brain, liver, spine, if recommended by radiologists. Here, for example, lymphatic, multiple metastasis in both lungs, metastasis in the adrenal, and also CT guided biopsy can be done. And also the local treatments can be done also in case of cancer. So this is the T staging for the lung cancer, and also all of this can be answered by CT. Imaging the head and neck tumor, ultrasound can be used in the beginning. It can differentiate cystic from solid lesions. We can see the white salivary glands. Guided biopsy can be taken by ultrasounds. CTs is a baseline study to evaluate the whole region from the skull base to the tracheal bifurcation. MR has a bit soft tissue informations, and the PET CT can be done for tumor recurrence and tumor extensions or residual tumors. So the accuracy, the local staging accuracy by MRI, by CT, more than 90%. Lymph nodes accuracy by CT 80%, and by MR the same. For MR, the local staging accuracy is reaching 95%. For example, here nasopharyngeal cancer extending to the parapharyngeal soft tissue. This is T2, considered operable, but this one here extending to the posterior fossa. So this one is T4, which is considered inoperable. In the rectal tumor, ultrasound can be used for transabdominal ultrasounds to see in the beginning. Then the primary study is MRI. The best evaluation of the tumor extensions beyond the muscularis propria, and to determine also the resection margin and fate of the adjacent structures. The CT can be done for distal metastasis, and the sound and CT guided biopsy can be taken from the liver if there's a liver lesion. This CT for whole body informations, distance, extensions, and for recurrent tumor. For example, here you can see the tumor here in the rectum, and this is the liver lesions. Most of the time, we can diagnose a metastasis from the CT. Accuracy reach 85% of the CT. MR is the best for T staging. The accuracy is more than 90%. And sometimes the radiologists will recommend liver MRI, which here the accuracy reaches more than 90%. Here's the example. This is the tumor here. It does not extend beyond the muscularis propria, so this is T2. This one, there is extension beyond the muscularis propria. Here you can see, so this is T3. And this patient needs chemoradiotherapy. And here metastasis by MRI. MRI also has a role in restaging the patients, and this is called MRI tumor regression grading. Can be assigned by radiologists and reporting the MRI. So next imaging is the prostate cancer. Ultrasound, the first information, transabdominal ultrasound in general, then endorectal ultrasound for prostate. Color Doppler can be used. MRI is the best modality for prostate to get accurate information about the tumor and tumor spread and staging. Bone scan can be done for metastasis, and CT for evaluations of the distance metastasis also. This CT for current cancer and for whole body information. So, screening-based aid is not reliable. The diagnosis will be made by pulse-vector ultrasounds and pulse-guided biopsies. Staging MRI for capsular penetration, so to say, and for similar physical bladder or rectal invasions, and also for nodal staining. This is called PIRATS. The radiologist will assign conclusions, the findings from PIRATS 1 to PIRATS 5. PIRATS 1, the clinical significant cancer is highly unlikely, whereas PIRATS 5, the clinical significant cancer is highly likely. And this is example for PIRATS 5 cases. Imaging in gynecological tumors, ultrasound for general transabdominal ultrasounds and endovaginal ultrasounds can be done. MRI is the best modality for gynecological tumors. CT for distant metastasis, ultrasound and CT guided biopsy for lymphadenopathy and metastasis actually. This CT for whole body information. This example for cervical tumor. This is endometrial cancer. The accuracy of MRI is more than 95 in case of cervical cancer and more than 90% in the endometrial cancer. This is Vigo staging of endometrial carcinoma, and this is for cervical carcinoma. All of this can be achieved by MRI. What about the ovarian tumors? So, ultrasounds can answer most of the questions that ovarian tumors can be used as a first line, and most of the time distinguish cystic ovarian from complex ovarian lesions or solid lesions. The CT can be done for lymph nodes and distal staging. The MR only in cases recommended by radiologists, so not all of ovarian lesions going to the MR. Ultrasound most of the time will answer the question. Sometimes the radiologists need MRI to further evaluations of the lesions. And sometimes the MRI also is not possible to make accurate diagnosis when you have 6 of time. Kidney and pancreas, CT is the primary modality and can answer most of the questions about the solid lesions, RCC or pancreatic solid lesions. MRI only indicated in some cases of pancreatic cystic neoplasms and cystic kidney lesions. It's not clearly seen in that CT. This is, for example, is the Bosniak classifications for renal cystic lesions. The radiologist will give final assessments from 1 to 4 for new malignant lesions. I will talk about the role of interventional oncoradiology. It's actually diagnostic or therapeutic. Diagnostic, we have digital subtraction imaging. It can assess the vascular morphology and morphology, neovascularizations and cancer results. Guided biopsy also can be taken by ultrasound, CT, MRI, or fluoroscopy, either FNA or core biopsy. Therapeutic, first tumor demolition. The tumor demolition by RFA, radiofrequency ablation, or laser wave, or percutaneous ethanol injection. Intravenous therapy, dilatation, stenting, embolizations, and chemo perfusions, or extravascular therapy, percutaneous drainage. So this is example for this case. This is example for chemo embolization. The cancer vessels is blocked. And the guided biopsy here from the kidney by using CT, and here from the liver using ultrasound. The follow biological data, and this is significantly affects the decision. So it depends on the multidisciplinary approach between the radiologists and other divisions. So in conclusion, the role of conventional radiology evaluation of the tumor is limited. Ultrasound is excellent for superficial lesions, abdominal organs, but not for deep lesions or bony tumor. MRI and CT are the basic modalities for cancer evaluation. MR has an advantage of severe visualization of soft tissue. The CT has a quicker examinations. This motion artifact is very important in CT, and severe visualization of the cortical bone. This CT is to detect distant metastasis, common disease, and to evaluate therapy response. And yes, of course, the radiologists have an important role in oncology patients. And as Dr. Mohamed said, multidisciplinary approaches are very important. We are doing an KMC, GI tumor boards, lymphoma tumor boards. This is very important for the final decisions regarding the patients. We heard about the clinical oncologists, surgical oncologists, and also we take the feedback from the pathologists. So this is what I have. Thank you. Any questions? So A, B, and C. I think the C, most of the women imaging radiologists, they are going for biopsy in case of C, because C is close to biopsy 4. In A and B, most of them they wait, they commence a follow-up mammography, or they are doing like MR or ultrasounds.
My second question is for those patients admitted for anemia for investigation. And by the way, the PET-CT showed that they have multiple areas in the colon with thickened mucosa. How can we manage this case? We send them to the gastroenterologist to do a biopsy, and they refuse because the lesion is in the mucosa itself, in the muscularis propria, not outside or inside the lumen.
You mean this in CT or MR?
Yes, CT.
So the CT, I don't know, you are talking about polypoidal lesions or thickening the wall?
No, they said that this is anemia for investigation, and CT showed multiple areas of thickened mucosa, and you should take over the case to manage as a malignant disease. How can we manage without biopsy? And you cannot do a biopsy, and the gastroenterologist cannot do a biopsy.
So I think you mean there's a wall thickening, because in the CT it's difficult to say this is because of the lesions, and there's some polypoidal lesions in case of...
Without any polypoidal lesions.
So...
can I answer? If patient has thickening of the colon, he should go for colonoscopy then for diagnosis. As an oncologist, we have no role without confirming biopsy. So this patient should go to colonoscopy to confirm diagnosis, then he should be managed after that. But oncologists will never take him without biopsy.
And also, I think radiologists, they have few signs differentiating ischemic or inflammatory or oncological. So the thickening, is it diffuse or localized thickening? If it is localized, it's any adjacent significant vascular, this will favor inflammatory cause. Is there a lymphadenopathy? This will favor also malignant cause or distant metastasis. And in case of suspicious thickening, biopsy is recommended.
Thank you very much.
Thank you, Dr. Fatih Salam, for this review. The second talk will be about the role of nuclear medicine and PET scanning in oncology by Dr. Zain Hasib.
Assalamu alaikum wa barakatuh. Good morning for everybody. Thanks the radiology organizing committee for doing this great workshop on the nice weather in Mecca, and welcoming for our colleagues from the oncology unit. I hope my lecture will be enjoyable and informative for everybody. I try to clarify at least some of the words which is usually not understood easily by the oncologists and the report. By the way, I'm Zain Hasib, consultant radiology and nuclear medicine in King Saud University of Riyadh. Bismillah, I will start the history of nuclear medicine, which is discovered by Marie Curie, she took a Nobel Prize for the discoveries of radioactive material. And you will read the words of radiotracer material. Usually it will be written in the bottom of the reports of the nuclear medicine report. The concept about the tracer, it was a funny story. It was discovered by George Hevesy. He was a student studying in Manchester, and he was thinking about his meal it was making by lithography. So just to make himself is it sure by made it by lithography or not, he put a radioactive material in his food, okay? Then he saw that it's lighting. Then he discovered the radiotracer theory on 1911. He took, by the way, Nobel Prize on the same year, 43. Usually the nuclear medicine and PET-CT, it will cover oncology, neurology, and cardiac, but we will discover today the oncology part of our nuclear medicine procedure. We have diagnostic, therapeutic imaging, and non-imaging part, but we will touch today the diagnostic imaging procedure. A little bit I will touch the therapeutic portion. The non-imaging we will not talk about it. The power of nuclear medicine, because it usually covers the functional imaging, and it takes usually whole body images to assess mostly the metastasis or if there is any infection. Usually the difference between the diagnostic imaging and nuclear medicine, the role of diagnostic imaging usually to diagnose the disease, staging, determination of the extent, and provide information out of the tumor and prognostic evaluation. The instrumentation usually what we are using, whole body imaging, is it planar imaging or tomographic? This presence of the tomographic portion, which is the presence of CT in the presence of the planar imaging, it adds a vision of anatomical detail. So this is the split portion, this is the CT, this is the fused image. The usual part it was, this is the whole body planar imaging, and this is the PET-CT. It has the CT component and the PET part. So I will treat nuclear medicine. I hope by the end of this lecture, it will move from unclear to clear medicine, and you will see the specificity of our imaging. You will see the higher specificity of the imaging by using the CT component involved in general nuclear medicine and the PET-CT. Presence of molecular probes. If anybody of you surgeon, he will use the molecular probe in imaging of parathyroid, or in cases of breast CA, an imaging of lymphoscintigraphy. Also, we have a rule now on the radiation oncology by PET planning for contouring and assess the size of the tumor before the radiotherapy ablation. So usually the imaging, the diagnostic part, which is usually done on the radiology department, is based on the regional anatomical information. But in nuclear images, usually we have a quantitative estimation of the regional biochemistry, receptor status, and so we can overcome a lot of sampling error or a lot of unneeded biopsy. What we are usually doing in the nuclear medicine, what we have to supposed to have, the radionuclide material and the radiotracer. Radionuclide usually coming from cyclotron or from generator or reactor. The radiotracer production, this is which is part of the radiopharmaceutical, usually as a molecular organic material is combined by radioactive. Then it will be injected to the patient. Then we get the gamma ray detection by SPECT or PET imaging, then we will get the image. So the radiopharmaceutical, it has a radionuclide portion. Pharmaceutical, usually it's a protein or inorganic or organic combined. You see in the report, technetium NDB, like in this example, or iodine MIBG. So you will see organic molecule and you will see the radioactive material. And you will read the special usually terminology in nuclear medicine report. Hot, which is mean photon rich, or cold, which is mean photon poor or photogenic area. I will start with the commonest procedure usually we are doing it in the nuclear medicine department to assess bone metastasis or bone tumor and soft tissue. This is the commonest procedure for assess vascular skeletal. Usually we are using technetium NDB, image the patient after 3 to 4 hours post-injection. Usually this I think commonly widely because it's easily to to have the technetium generator, and it's inexpensive. But its disadvantage, it's sensitive but not specific. This is the combination technetium with MDB or HDB. Usually the MDB is a non-seeking advanced agent. And this is the two agent which is used on the PET-CT, either FDG or sodium fluoride. I will talk in detail about it when we talk about the PET-CT. What we report usually on the bone scan images, either this lesion is single or multiple abnormality, regional or widespread, uniform or variable intensity, and usually we localize the abnormality. You can see here, this is osteosarcoma. It's only osteosarcoma limited to the distal tibia, distal femur, sorry, and there is no distal metastasis. We can see here widespread, or we can call it uniform metastasis, super scan. And this is an example for how we can assess the vascularity of the aggressive tumor. We can see on the X-ray, it's a huge soft tissue mass with cortical destruction of the distal, of the mid shaft of the fibula. And we can see the vascularity, how it's surrounded by increased the vascularity in the blood flow, in the blood pool. We can see there is increased blood pool accumulation and the central photopenic, and this is on the delayed images. This is an interesting case. She was 47 years old, female. She came with history of low back pain. They start to investigate her, as usual, by bone scan. We can see the planar images. If you notice, this is masking for renal bladder. We can see there is abnormal tracer uptake noted on the left sacroiliac joint, okay, in the anterior and the posterior image. When we did the post-void images, it's still clear. We can see that there is increased tracer uptake. We did the SPECT CT. You can see this is the center. This is this SPECT portion, and this is the fused images. This is the CT, just an wall window. This is the soft tissue window. We can see there is a soft tissue mass extending from the left sacral foramina, extending and across the left SI joint. The surprising was, they did the mammo for this patient, it was normal. They suspected this patient has low back pain from bone metastasis because of the age. It was normal. We biopsy that lesion, it became a plasmacytoma. And usually how we diagnose the plasmacytoma if it's started from multiple myeloma? By imaging. Usually multiple myeloma is diagnosed simply by X-ray because you will find multiple lytic lesions. But if the patient has a plasmacytoma component or soft tissue, or she has associated fracture, you will see it on the bone scan. The commonest thing also on the bone scan, usually the spinal metastasis, which is usually most frequent site for metastasis from lung, breast, or prostate. Majority usually up to 35% they came with multiple metastasis. We can see this is example for to see if there is a focal area of intense tracer uptake noted in the pedicle. And this is a worrisome size for nuclear medicine or for the radiologist. If he see on the images, even if the X-ray, if he saw missed pedicle, okay? Because usually the metastasis, it will go to the pedicle portion of the vertebrae, even if it's solitary, but it's focal and increased intense tracer. So we did a SPECT CT, it was very intense, and it's proved to be metastasis. The second most common metastasis to the bone, usually prostate CA. A prostate cancer, usually it can be detected early by ultrasound, but usually it's given poor delineation for the prostate and CT. The staging usually done by MRI. After that, usually they ask for bone scan, which is usually sensitive but not specific, and it has not been requested for all patients with a prostate CA. Why? But we don't have a surgical here. We don't have to usually request a bone scan because it may be give you, if you did 100 patients bone scan and he doesn't have rising PSA more than 10, maybe you will get a false positive result by the presence of arthritis or fracture or anything. So you don't have to request a bone scan if the patient, and even sodium fluoride with CT, unless if the patient is highly indicated or the patients have recurrent after treatment or post-surgical high suspicion of raising PSA, which is a tumor marker, or if the patients have a pain. The new trend now used in the nuclear medicine, specific for the prostate CA, the gallium-68 PSMA PET-CT, because this is specific for diagnosis and therapy for for diagnosis and therapy of prostate CA. And this is used now, by the way, on the Germany and Australia. It has an excellent good outcome on the therapy of the prostate CA. This is another tracer which is used, choline. It's usually labeled with the BSMA. So in the therapy part, they will use lutetium-177, or they will label it with choline for diagnostic. So this is example for prostate CA. He was 68 years old, diagnosed with prostate CA. His level of PSA was 95. We can see the bone scan. The patient denied any pain. The CT was negative. The bone scan was clearly negative. This is a pathology. This is a fracture. We can see it's a positive sodium chloride PET CT. This is the history of FDA approval of the fluoride. I will not go in detail for that just for the time. I put just two papers, anyone interested, just to go to look for the detection and the therapy of prostate CA. We have other agents to assist of bone metastasis. Okay, if the primary is not given osteosclerotic lesion or it's not caused from body tumor, like usually thyroid cancer, if it's metastasis to the bone, usually we are doing iodine, whole body scan, and we can use a SPECT CT for localization. Because we can see here two focus of uptake noted on the chest. We don't know is it bony or chest lesion, bony or lung. So when we did the CT, we can see in the lung window there is high intense tracer uptake noticed on the lung. So this patient has thyroid cancer residual with metastasis to the lung. This is pediatric patient. So in pediatric, usually this is the commonest tumor after brain tumor in pediatric. We can do for them the iodine MIBG for neuroblastoma. We can see there is extensive bone metastasis. And lymphoscintigraphy also, this is from the commonest procedure. Usually we do in nuclear medicine, we have at least 2 to 4 cases per week to assess the Sentinel lymph node on the patients for going to mastectomy, or in patients also with melanoma. What is the role of lymphoscintigraphy? Usually to decrease the complication of upper limb lymphedema and to upstage the patients of this lymph node that was not positive in ultrasound or in MRI or in MRI. How we do this lymphoscintigraphy? Usually we inject peridermal or peritumoral. We give 4 injections with an nanocolloid, or there is now a receptor binding agent called Lymphocin, but it's still not used here, but it's FDA approved and used outside. It will assess how it's the lymphatic mapping, and it will detect for dysentery lymph node. During the OR, they will get a benefit also from the molecular probe inside the OR. Then they will take and sample this lymph node. They will send it for fuzzy section. If it's malignant, they will do axillary dissection for tumor clearance. If it's not, they will do it. Also from the commonest procedure, usually we do thyroid malignancy, and I will go for octreotide and MIBG for neuroendocrine tumor. What is the signs of malignancy of ultrasound for thyroid malignancy, which is usually in here now, it's common with thyroid CA. If we can see the lesion is hyperpigmented with microcalcification, irregular margin, and increased vascularity. This is highly suspicious. The patient has to go to FNA. After that, the patient has to undergo for surgery for total thyroidectomy. Then he will come to the nuclear medicine department to do whole body scan to assess if there is residual or metastasis. We will go for the therapy part. So this is re-ablation. We can see the start of attack. Then the follow-up scan. We can see there is complete resolution of residual tumor. In neuroendocrine tumor, I will go for the commonest tumor. Usually the neuroendocrine tumor, it's because it's functioning, symptomatic, and usually there and the age. The treatment with radioactive material, the outcome is only 30%, but in the diagnosis, it's excellent in nuclear medicine. The most common 2 agents usually we are using it, octreotide and MIBG. Octreotide is a somatostatin receptor agent. The half-life is 2 hours. Usually it binds only to the subtype of 2, 5, and 3. And most of the common nuclear neuroendocrine tumor, it will be subtype of 2. So usually it will be positive in octreoscan. This is the distribution of the octreotide. This is commonly seen in the carcinoid. I written here interfering drugs, this is just for the clinician. Usually the neuroendocrine tumor, the patient has to be prepared to check all the medication he's taking it before to go for octreotide scan or even for the MIBG. This is example of, we can see this is a midline, avid region. On this big CT, we can see the clear mark of carcinoid. This is typical feature of carcinoid. You can see the tethering, concentric mass. Okay, which type of the tumor can be false negative in octreotide scan? Usually, if the patients have this kind of the tumor, usually will not request a octreotide. Insulinoma. Okay, the insulinoma usually, if the patient has insulinoma, it doesn't have to go to the octreotide because the insulinoma doesn't have any somatostatin receptor. Okay, and this is an example of typical appearance of pheochromocytoma. This is the specific agent which usually are using on the PET-CT, gallium-68.8 or DOTATOC. This is specific for the neuroendocrine tumor on PET-CT. We can see how it's very small in the octreotide scan. We can see it more obvious on gallium-68. Then we can see it on the dedicated diffused images. The MIBG mainly used in the commonest use with the neuroblastoma in pediatric because it's analog for catecholamines, adrenergic and noradrenergic uptake. Usually it's concentrated in neuroblastic cells and sympathomimetic tissue.